Hi, my name is Else Sandset. I'm a stroke neurologist based in Oslo, and it's my great pleasure to have Professor Craig Anderson from the George Institute in Sydney, Australia, to talk about one of the presentations in the large clinical trials session. Craig, tell me a bit about what you just have presented.
Oh, thanks, Elsa. The results of the imaging analysis for cerebral ischemia amongst participants in the ENCHANTED trial. Many people will remember we presented the results in the Lancet several years ago, showing that a more intensive blood pressure control to a systolic target less than 140 within 1 hour amongst thrombolyzed acute ischemic stroke patients was safe, but did not improve functional recovery despite a clearly significant reduction in reperfusion intracerebral hemorrhage. So in some ways, it reassured us that a more intensive target was safe, but it caused us a little bit of uncertainty as to why would there be a clear reduction in intracerebral hemorrhage, and particularly the very severe hematomas, but that didn't translate into improved clinical outcome. It adds to the controversy as to whether there may be some interaction of more intensive blood pressure control on cerebral perfusion, the cerebral ischemia, the penumbra, and that may have offset any benefit that could arise from reduced hemorrhage. So we had always planned to examine the cerebral ischemic footprint in our participants, but as you could imagine, with over 2,000 scans, and this is 2,000 patients with scans, many with repeat scans, that's a lot of work. And so we've had a small army of research fellows doing the imaging analysis over the last 18 months, 2 years. With all of that work, we have not shown any change in cerebral ischemia by the intention to treat a more intensive target. Most of our scans were CT, so it's a pragmatic approach. You could argue CT is not so good at picking up the subtleties of ischemia. We had less than 200 MRIs. But anyway, we looked at the analysis just on CT and MR, anyone with any scan at any time. We could not see any change in the volume size of cerebral ischemia between randomized groups. The advantage of this work is it's randomized evaluation. There is a lot of observational studies, but this is the only randomized evaluation of an intention to treat more aggressively, measuring the cerebral ischemia. And it provides us with reassurance that to that 140 target, there does not appear to be any major harms in terms of adverse effects on the size of cerebral infarction in thrombolyzed patients.
I think the results, Craig, are they're reassuring. As you said, you only have or mainly have CT scans, and so the subtle differences, but perhaps the subtle differences are not what will lead into poor outcome if the differences are so subtle. In the ENCHANTED, I would say blood pressure was actually quite well controlled in both groups. Do you think that could have influenced your results here as well?
Yeah, certainly. Also, when you do a clinical trial, you want to ensure that there is a clear difference between the randomized groups. So despite our intentions for the intervention group to be treated more aggressively, the difference between the intensive group and the control group was smaller than we had anticipated. Overall, it was only about 7 millimeters systolic in the overall group at 1 hour, And in this particular subgroup with the clear repeat imaging, it was only 4 or 5. The control group did receive treatment, and then obviously following reperfusion, there is a natural tendency for the blood pressure to go down. So you're right. One of the arguments against no findings was that the blood pressure difference was small between the randomized groups. But on the other hand, it is a randomized evaluation with the intention to treat to less than 140 that did not show any major change in the cerebral infarction footprint.
And this, Craig, this is a bit more of a general question, and I think, I mean, you have extensive experience not only in ischemic stroke trials on blood pressure, but also trials on intracerebral hemorrhage. Are we picking the right endpoints? Do we think we will see an effect on functional outcome? Do you think that is realistic in blood pressure trials? Or do you think we should think about more blood pressure management in also ischemic stroke as more of a supportive treatment that we do in addition to other treatments? And it's the synergy of several treatments that might provide the benefit on clinical outcome.
Yeah, well, all very good questions. Look, I think it's fair to say that the benefit of blood pressure lowering is small. It's not like thrombolysis or endovascular treatment or any other surgical intervention. It's a small absolute benefit. So it's very hard to see that realised in the individual patient. I think the issue of blood pressure control is part of a protocol for systems of care. That's where the benefit will be realised. I always think it's a little bit like aspirin. We're very comfortable in giving aspirin, but it's a very modest overall effect. And we've shown that it can reduce hemorrhage in the brain, and any blood in the brain is bad. We've shown that it's safe to go beyond the guideline recommendation of 180, which has stood the test of time now for over 2 decades. Going to 140 appears safe, both in intracerebral hemorrhage and ischemic stroke. We still don't know what's the optimal target to go beyond that. In endovascular treatment now, for large vessel occlusion, there is a view to be even more aggressive to less than 120. We don't know whether that's beneficial or not. And the other thing is that over the 24 hours, 72 hours, fluctuations in blood pressure are also related to poor outcomes. So I think the time's coming where we do need to ensure we're monitoring blood pressure carefully as part of a system of care in our patients, be a little bit more aggressive. We need to be mindful of avoiding too low dips and to ensure there's smooth control over the period of time in hospital. But we're still not sure of that zone, that optimal zone. And we need a little bit more data on that.
And the optimal zone might not be the same for all patients. Correct. On a general level. I think we also need to perhaps move more into differentiating between if you have a large vessel occlusion, if you have small vessel disease, if you have the vessel open, if you don't have the vessel open. I always tend to worry a bit about, or when you have the patients with a very high blood pressures and you don't see the blood pressures dropping after you have reperfused the brain. I'm wondering what's going on in these people's brains, and is blood pressure, is it reflective of what's going on in the brain, or is it something we should modify it in order to treat what's going on in the brain? I don't know what your views on that are, Greg.
Yeah, look, I agree entirely. And the problem is that we have great difficulty monitoring what's happening in the brain in real time. We can look at the blood vessels as snapshots. We can look at the overall structure of the brain, We can do transcranial Doppler for the large vessels, and we all use this information to imply what's happening metabolically in the brain, but actually we don't really know what's happening in the brain. And we have got some nice physiological studies in animal models, which we try to interpret, may also be applied in the human brain, but we're not sure of that as well. So I think we need some better biomarkers to guide us around that. We're good at picking up harm, but we, for blood, there's blood in the brain and swelling, but picking up ischemia in real time is something that we're missing in stroke medicine.
Yeah, no, I agree there, and I think the analysis you have presented here it's so important that we get more data on imaging, even if it's pragmatic. It is CT. We are not identifying the subtle changes. At least it is more than what we had before, and it is reassuring that there's not major differences in the ischemic lesion, and we are preventing hemorrhagic or hemorrhages, which I think is very reassuring, and that is of course what we all fear when we give thrombolysis. I think if you put together the data on ICH, blood pressure lowering in ICH, and now also with ENCHANTED, it is due for what you already are doing, a pre-hospital trial where we lower blood pressure in the ambulance. So although we have some worries regarding the hemorrhages in right 2, but there are many explanations for that. But I think it is important that we perhaps we can prime the patients before they come to the hospital, and I think that's one important approach, and might even be able to treat patients faster in hospital. So the results of INTERACT 4 will be very interesting.
Yeah, I agree. Also wait for some results from ENCHANTED 2, MT, and as you know, we're examining a care bundle of intensive blood pressure lowering, glycemic control, treatment of pyrexia, and early reversal of anticoagulation in a major INTERACT 3 trial, and we will be presenting those results next year.
Well, thank you very much, Craig. I think it was great talking to you, and we look forward to your future presentations.
Thanks, Elsa. Thanks, everyone.